Okay, we're going to be talking about congenital heart defects. Before we get into congenital heart defects, let's first talk about it's kind of a little bit of a review on cardiac stuff. But what we're going to talk about, we're going to talk about ventricular septal defects, atrial septal defects, which are very similar, and then we'll be talking about Tetralogy of Falot. That one's kind of cool. That's why I like to talk about that one, and it also seems to be one of the ones that they like to test on. When you take tests like HESI tests, ATI tests, things like that, seem like to talk about tetralogy of a Falot. At least bring it up in a test question. Uh, so the first thing we'll do is we'll talk about flow, how blood flows through the heart and through the system, through the lungs. You got to kind of get that down. Anyway, right atrium. So you got a blood spot here. Boom, goes through. So right atrium, goes through the tricuspid, right? Tricuspid valve. Let's draw. Let's make this look like a valve here. Got a little trap door there. Right, goes through the track into the right ventricle. Right ventricle. I'm gonna write the whole thing out here. From the right ventricle goes up through the pulmonic valve, semilunar pulmonic valve they call it, but we'll just call it the pulmonic valve. Pulmonic valve. And through the pulmonary artery. I always want to call that a vein because it's blue, but it's kind of reversed if you remember right, it's reversed when you're talking in the pulmonary circulation. The arteries are non-oxygenated and the veins are oxygenated because they're going away from the heart to the lungs. So they're called an artery. Boom, off to the right and left lungs, right? So that's where it goes. Goes to the lungs, comes back into the left atrium. Let's circle these guys here. Right, left atrium. Right, it's coming back through here. Oh, draw that little vessel in here. So now you got your drop of blood over here in the left atrium. Goes through the mitral valve. Man, it's so bad you guys ain't gonna be able to read it. Mitral valve into the left ventricle. Right, and when that pumps, it's going to go up through the aortic valve. Again, the aortic valve, sometimes called the semilunar aortic valve. And out through the aorta, out to the blood, or out to the body, right? Then it returns from the body through, might as well be returning here, unoxygenated, through the superior and inferior, I'm going to have to call that underneath, and then it kind of comes in through the sinus here, inferior vena caves, right? I'm not going to bother writing them in there. So that's the blood flow through the heart. The thing to remember about the heart, though, with these defects that we're going to be talking about, is you got to think about what work is being done here. You've got the atria, which are pumping blood down into here, right? You think of it this way. During diastole is the time that the heart is relaxed. During diastole, the entire heart fills. So during diastole, the heart is relaxing. It's not pumping now. We're in diastole, and the whole heart fills. Both ventricles and both atria fill up. They just fill up. And after they're both full, the atria contract and pump down into the ventricles, right? So you can think of it, you got your ventricles here like this, and they're filled up. You've got on top of them two atria, and they're filled up. The atria pump down in there, so that just blows this up just a little bit. So it's full, Boom, blows it up right before it beats. So this beats, then that beats, right? Top beats, boom, bottom beats, right? Top beats, boom, bottom beats, right? So it spreads those ventricles out just a little bit further. It's like if you're taking, because that's just to get a little bit more force. It's like if you're taking a rubber band, you take it, you pull it back a little bit, let it go. But if you take it and then you pull it back further and let it go, that extra stretch will give it more power. That's Starling's law. See that on test questions too, at least the ones that I like to put out there, just to make sure that you were paying attention, right? So by Starling's law, further you stretch something back, the more force it's going to have when it goes out. So that's what we're doing here, and we call that the atrial kick. That's what the top part of the heart pushing down into the bottom of the heart right before it goes. The bottom of the heart sitting there, gets overstretched right before it pumps, more power, right? So that atrial kick is they say if you're in atrial fibrillation, what happens then is the top part of your heart is just fibrillating. It's not beating. So you don't get that atrial kick. Bottom part of the heart is still beating, right? Still doing its thing, but it's not getting that stretch. So it's losing some of its power. They say that you lose about 20% of your cardiac output when you lose your atrial kick. So that's what's going on there. So down here, these do not have to be real powerful. The atria, they do not have the force behind their contraction that the ventricles have. Much higher pressure down here in the ventricles than there is up in the atria. Now, and that makes sense. Now, the left atria is pumping out to the entire body, while the right atria is pumping out just to the lungs and through the lungs. They are both pumping out the same amount of blood. One's not pumping out more blood than the other with each contraction. They're pumping out about the same amount of blood. So this guy here is pumping a lot further, right? So it has to pump a lot harder, right? And if you think about it, if one side pumps more than the other side, this is a closed system. It would start backing up somewhere, and I'll show you with a different diagram here in just a little bit. But so right now, what we got is we've got a higher pressure system down here than what we have up here. And which one of these ventricles, the left or the right ventricle, is going to be pumping? Is going to be a higher pressure? Which one's got to pump harder? Obviously, the left ventricle has to pump harder because it has to pump out to the entire body. So the highest chamber, the highest pressured chamber should be the left ventricle, right? The left side as a whole is higher pressure than the right side because even the right atrium has to pump down in to the stronger stiffer left ventricle, right? It's more muscular, so it's got to pump a little bit harder. So you do have higher pressure in the left atria than you do in the right atria, and you have a much higher pressure in the left ventricle than you have in the right ventricle. So those dynamics are kind of important to know when we start talking about blood flow and some of these different congenital anomalies. Okay, set that there. I go like this here. A couple of pumps. These are the cylinders. They're supposed to be pumps, right? From this pump, we've got a hose coming out like this. Got a hose coming out like this. That's a hose. And I'm just going to go ahead and color code these just because I like playing with my colors. I've got a bunch of colors, might as well use them. And that there, and this one here is representing the lungs. So doesn't matter. Actually, I usually do it the opposite of the way I got it, but it don't matter. Lungs. Body. So now you got these two pumps. This is pumping over here. This one's pumping over there. Going round and round and round, right? So as this is going around, we got the left one is pumping out to You got one pump that's pumping out to the body and back here, back over here to the other pump. This is pumping back. Both of those pumps have to pump out the same amount at the same speed. And like I was saying, the left one has a lot further to go. Same amount at the same speed, but it's got a lot further to go. It's got to push a lot harder to make that happen. But what will happen, let's say the bearings start going out in these pumps, right? The bearings are starting to wear out. First place you're going to see that problem is going to be over here in this pump because it's pumping out to the body. I should have made that just squiggled all over the place because it's going through a lot more, right? Maybe I'll draw some little resistance lines, right? Some little resistance lines. So it's got a bigger job to do is what I'm trying to tell you as it's pumping over here. But it's still got to be equal in order for this fluid to just, this blood to just keep going through there. So bearings are starting to go out. This is where you're going to see it because it's got a harder job to do. That's it. And you learned that last semester that the left ventricle is usually where you'll see your heart failure in the beginning, right? So this guy here isn't keeping up with this guy. This guy's still pumping out to the lungs at the same speed, but this guy's not pumping it out of the lungs, right? It's not pumping out of the lungs into the body at the same speed, so it backs up behind here. So you end up with this. With this backup pressure back in here in the lungs. If the left ventricle is what's going out, you get it in the lungs, right? If the right ventricle is going out, you get what's behind it, and it'll be the body. That's where you'll get your pressure. Real quick, I'm going to talk about the conduction system, just so you can kind of see this and kind of have a little bit of an idea what I'm talking about when I tell you that the conduction system, your heart system is being, you're going atrial fib or something like that. So you come up here, you got the sinoatrial node, SA node. That should be the guy where all heartbeats originate, right? Comes out here, goes through the ventricle, and actually comes straight across through this side. Comes down in here to, these here are called the atrial conduction pathways, through to the AV node. Boom, right? Then it goes out through the bundle of His, then down the right and left bundle branches. And then the Purkinje fibers are right on the end. The only reason I'm drawing this out like this is so that you can understand. Now this is the ventricles. I should have probably separated them so that you could see that, right? So starts up here, comes down in here. So when you get stretching of the cardiac muscle and displacement of the cardiac muscle, it can affect these conduction pathways. These aren't nerves. These are conduction pathways. What that means is they are some of the myocardial cells that receive and transmit electrical impulses much more readily than the other ones. And so the impulses tend to follow that. But an impulse can actually be generated or follow through in any of these myocardial cells. But these are the pathways that they prefer to follow. And if you stretch that muscle and move that muscle around, these pathways get distorted. And some of the things that we're going to be talking about might distort, especially this AV node, because it's right in here, right in the middle of where all this stuff is going on, where all these muscles kind of come together. So that's it on the conduction pathways. SA node, atrial conduction pathways, AV node, bundle of His, right and left bundle branches out to the Purkinje fibers, or the little fingers at the end that go into the cardiac muscle. Let's see, what else do I want to tell you? Okay, now there's some rules about the heart that you kind of want to remember. We know what the heart rate is, right? Heart rate, some people will call it the pulse, right? That's the amount of times that the heart beats in 1 minute, right? We all know that. So, right, and that's beats per minute. And we got stroke volume. I'm guessing you probably learned this last semester, but stroke volume is the amount of how many milliliters were pumped out with of the left ventricle with each beat. Right, so that's how many milliliters you pump out. Volume out. So stroke volume, cardiac output. I'm just going to put CO there for cardiac output. And that is the amount of blood put out in 1 minute. So this is the amount of blood put out for every beat. This is the amount of blood put out in 1 full minute. And this is the amount of beats you have in 1 full minute. So think about it. Your cardiac output, your heart rate, the amount of beats per minute. Hey, I forgot the T in that heart rate. Why the hell didn't somebody tell me that? That doesn't even look like it now. Look at that. Crap. Okay, does that look more like heart rate? I don't know. Anyway, so your heart rate here is, so you got your heart rate, the amount of beats per minute, got your stroke volume, the amount of blood per beat, and this here is the amount of volume in a minute. So if you take the amount of beats times the amount that was put out with each beat, you will get your cardiac output. So cardiac output always equals heart rate times stroke volume. So heart rate equals times stroke volume. Let's put stroke volume in parentheses there. So heart rate times stroke volume is your cardiac output. So in other words, when your heart beats faster, your heart rate, your cardiac output will go up, right? Because your heart rate's going to go up. You get a bigger number there, it'll make this go bigger, unless this is a smaller number. And just to let you know, usually when your heart rate goes up, your stroke volume goes down because you don't get as much time for the ventricle to fill up. So it's beaten before it really fills up is good. So when your heart rate goes up, your stroke volume goes down. So a lot of times when your heart rate goes real fast, your stroke volume gets almost at nothing. So your cardiac output is really low, even though your heart rate is really high. Let's see, what else we want to talk about? Preload. Your preload. I guess I'll talk about your preload. We don't need to talk about ejection fraction, but preload we will. Preload is the pressure in the heart right before and at the end of diastole. The pressure in the ventricle or at the end of diastole. So it's sitting there like this, and it gets blown up like that right before it beats. How much pressure is in that? That's your preload. How much blood do you got in there? So when you get an increase in your cardiac, in your blood return to the heart, you have a higher preload, right? So, and that's what your preload is. So you should know that. And then what's your afterload? Afterload is how much pressure does your heart have to overcome? How much work is your heart working against in order to pump the blood out into the system? So left ventricle, how much pressure are you working against? If you have that aortic valve, when I showed you the aortic valve, if that sucker is stenosed, you've got an increase in afterload, right? If you got really high blood pressure and you're having to push out into that pressure, you've got an increase in your afterload. Okay, now let's start talking about ventricular septal defects. Again, you get the picture of the heart here. So aorta, your aortic valve right here, your pulmonic valve right here, right? And of course you've got your mitral valve right, or I mean, sorry, your tricuspid valve right there, and you've got your mitral valve right here. So, in a, and we know how the blood has to go through there. We've talked about that. So, what we have with a ventricular septal defect is we get a hole in the heart. Usually happens kind of when they're young, or on birth. It's congenital heart defect. That's why we call it that. So you end up with this hole. Probably the most common place is right up here in that upper part, and this what they call the membranous part of the. And I'm even going to exaggerate that. Well, not exaggerate, but try to show that a little bit better. They call it membranous, the membranous area, because it's like just a membrane, so it kind of floats around in there. And in development, what happens is you end up with just this little nub that kind of grows up as it grows up, and this grows down. Now you got to remember, this is a three-dimensional figure. You might say, well, how are they going to meet up? Well, it's growing all the way around this inside of this thing. So as this is growing through, it's growing, all the way. It's three-dimensional, and this is growing up. So they kind of come up and they grow together. And as they meet in the middle, they kind of grow together, and they kind of have these fingers here. And then from the top, it's kind of coming down like this, and they kind of grow together. Well, sometimes one of these little fingers, for some reason, didn't develop well, and you end up with this little hole here. Right? So as they came together like this, you got one of them that's kind of missing, so they come together and you end up with this hole there. So you got this hole in the middle of this guy. So with that hole in here, and it's usually right there where the two of them are trying to grow together. That's probably the most common place. You can get it down in the muscular area. You get it purely up in the membranous area, which is actually what they'll call it, because that's where you'll see this problem. So you got this hole in here. So when the heart beats, instead of all of the blood going out through the pulmonic and aortic valve, what's going to happen? Some is going to squirt through here. Which way is that blood going to go? We talked about where the higher pressure was. Fluids go from an area of higher pressure to an area of lower pressure. We're not talking about osmosis, diffusion, or any of that stuff, things moving around in fluids. We're talking about the fluid itself, just plain old hydrostatic pressure. Right? If you got more pressure coming this side than you are in this side, it's going to go from the higher pressure area over to the lower pressure area. So you got a lot of pressure. We just said this guy has more work to do, so it's pushing out harder. It's got more oomph behind it. So as these guys both push, your blood drops. Some of it's going to squirt over here. Some of it's going to go up through here, right? And then you got your blue blood here. You got your blue blood in here. Some of it's heading up here, and you're going to get some oxygenated blood going back up here. So if you think about it, what's the problem here? The problem it's not a problem of hypoxia, right? You're not going to really have that problem because the blood that comes over here, it's been oxygenated. It's going to take an extra trip to the lungs, get oxygenated again when it didn't really need to go back there. But you're returning some of your blood back to the lungs that didn't need to go back to the lungs. But at least this is a livable defect, right? This is a defect that is not going to cause a big problem right now. More than half of these close up spontaneously on their own. Some of the ones that don't never really turn into a real big problem. Sometimes, though, they are a problem. If that hole is big enough that you've got this higher pressure in the left ventricle than what you got over here in the right ventricle, if that hole is big enough to convey that pressure, the bigger the hole is, the more it's going to increase the pressure in the right ventricle. Right ventricle pushing out to the lungs is not used to all that pressure. The lungs aren't used to it. The lungs aren't made to take all that pressure. So you can end up with an increased pulmonary pressure, right? Increased pulmonary pressure can run into problems. You can have problems with pulmonary edema. You can have frequent lung problems, things like because you're getting fibrosis in the lungs because they're getting scarred up because they're constantly getting beat on with this higher pressure. So then it would be something that would have to be fixed. And I decided I will just wait about showing how they patch these holes when I talk about the atrial septal defect. Might as well just do it once, but you can realize that it kind of works with both of them. So if it's conveying, it's not the majority of the cases, but sometimes it can be a problem where you're going to do that. It doesn't happen right away. right? Isn't going to happen, right away with this baby. It's going to happen in time. So this isn't something that they're necessarily going to take care of right away. They'll let the kid get a little bit older, maybe to where they can tolerate the procedure a little bit better. Because what happens is with this increased pulmonary pressure, over time, it damages the lung, right? And so over time, the person can end up with got a lot higher chance of getting congestive heart failure problems and things like that. So, and oxygenation problems. And another thing is when you are increasing the pressure over here, we normally have higher pressure here than here, right? Well, all of a sudden, you're increasing the pressure over here. The left ventricular wall is much thicker than the right ventricular wall. I didn't really draw it that way, although I should have, especially for this lesson. I should have drawn that this guy here is much thicker than, as I was starting to say. When you get this blood being, this pressure, this increase in pressure over here, because you're pushing blood off there too from this high pressure area, this guy here has to get stronger. So all of a sudden it gets stronger, and over time it gets stronger and stronger because you're working it out, right? So over time, it's good that pulmonary pressure just increases a little more and a little bit more as it works harder. And another thing is, it doesn't usually happen in the ventricles, but it's much more likely to happen with the atrials when we get up to there, is that this ventricle can actually get to the point where it is evening the pressure out, and maybe you won't have this left to right shunt anymore, right? Left to right shunt is what you get with the ventricular septal defect. And we're talking about ventricular septal defect, right? That's what we're talking about. Left to right shunt is what they get. Left to right shunt is not all that dangerous, especially if it's a smaller hole. But if it stays there, and it can cause this problem of increasing your pressure. So your left to right shunt could, if this guy equals out, you might start and get some right to left shunts, because this one's getting stronger now and the pressure is getting up. Not very likely. Doesn't usually match the pressure of the ventricle, right? But if it gets close, when you do something that can decrease the systemic resistance out in there, you can actually get this reversal in the shunting. And you don't really want the non-oxygenated blood going off into the system. But that, like I said, that's not the big problem. Big problem with ventricular septal defect is an increase in your pulmonary pressures, right? And that can increase more and more over time. One of the things that you might hear, and they might hear it right away when they're born, and might not, it might take a little bit before you actually hear it, is you can hear a murmur, right? And you'll hear a systolic murmur. Now, everybody knows your basic heart tones. Your basic heart tones are lub, dub, lub, dub, lub, dub, right? And now we got to talk about what that means. The atria contract and pump the blood down into here, so it increases the pressure here. See these trap doors that I drew in here? Little trap doors? Those things slam shut because they just increase the pressure down here. Lub. Then this thing pushes up in here, increases the pressure in these two arteries here on the other side of your pulmonic and aortic valves. Zoom, you push it up in there, and now those things, dub, slam shut. Slam shut, lub, slam shut, dub, lub, dub, lub, dub, lub, dub. Well, during that contraction, you're getting a squirting of blood through here. So you got lub, dub, lub, dub, lub, dub, lub, dub, lub, dub, lub, dub, lub, dub. It kind of sounds like it's one thing, and that kind of pulls off into the dub, lub, dub, lub, dub. It's kind of, I can't do it. I can't do it with my mouth. So instead of saying lub dub, it's either just go thump 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 thump, right? Because you're hearing that between those two beats, right? Because this is beat, right? That's during systolic, so they call it a systolic murmur, because it's during systole that you're hearing it, and you're hearing it after lub, before dub, and kind of. I never did like the lub dub thing because I just think it's totally inaccurate. Doesn't sound like lub dub to me. It just sounds like thump 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 thump. So what kind of symptoms, what do you think will happen with these people? I got it written down here. Smaller than expected, so the person can be smaller than expected, might not be a failure to thrive, but won't be as big as what you want them to be. Um, let's see. Frequent bouts of bronchitis, pneumonia, things like that, because you got this increased pulmonary pressure. So they're in pulmonary edema. They can end up with heart failure, uh, congestion in the heart, and I can do this. Endocarditis, right? The endocardium is this lining that comes right around the inside of the heart there. So a lot of times that might get inflamed, and that's inflamed to speak of. Medicines that you might see this person on. You might see them on inotropes, in a positive inotropic drug, and that's digoxin. They could be on that to try to increase cardiac output if they happen to be losing too much of their fluid over there. But that's going to be a case probably where they have to be fixed. They could be on ACE inhibitors, could be on diuretics, um, and both of those can kind of decrease the volume. Out in the system, right? If they're getting fluid overload, things like that, so you can take those to kind of decrease the volume and decrease the blood pressure, the amount of work out here that the system has to work against. If you decrease the pressure out here in the system, right? So you're decreasing the afterload. It's more of the blood will pump out here than through here. Right? When somebody is on digoxin, since I brought digoxin up, and whenever I bring up digoxin, I like to talk about it because it seems to be a favorite, even though it's not a medicine used as much as it was just 5 years ago. Um, it's still kind of a favorite as far as testing, at least from what I've been told by some of my students that graduate and are gracious enough to let me know some of the questions that they had that they say they didn't really know about. So, and digoxin was one of them. So when I bring up digoxin, I like to talk about the things about digoxin. When somebody is on a digoxin, you need a dig level because you want to make sure they are in the therapeutic level. You don't want them to be hypotherapeutic, or you're not doing any good. And you don't want them to be toxic because toxicity can run into problems. Toxicity can run into lethal cardiac arrhythmias. Before that, though, you usually will have problems. You'll see problems like you'll see nausea, vomiting, visual disturbances. They'll say like a halo around everything that they see, and maybe just some changes in mentation. They get kind of. And as far as you want to get to them before they have the dysrhythmias, like I said, they can end up with a AV block. Which, remember when I showed that out? Remember I showed you the atrial. You had the sinus node up here. You had the AV node down here. That blocks. Boom. So your heartbeat isn't getting through. It's not coming down, going through the AV node and then out down into the bottom part of the heart. So it's blocked. Luckily, we have escape rhythms down here, but they only go at like 30 beats a minute. So you're going to have a ventricular rate of 30 beats a minute. The ventricular rate is what matters because it's pushing out. Up here might be beating normal, but those beats aren't going anywhere. They're not coming down into here. They're not. This isn't following up on the beat. So that's one of the rhythm problems that you can have with there. You can also get atrial fibrillation is another problem that they have, and ventricular fibrillation. People with on digoxin, if they get toxic like that, sometimes they go into ventricular fibrillation. What will that do? Think about it. The ventricles, instead of beating, will just quiver. Guy's dead. Unless somebody's there to cardiovert them or somebody to at least start CPR, they're gone. So it's pretty lethal. So that's why you're always going to monitor their levels and see that they are in that therapeutic range, and you'll treat them accordingly. Let's see. And there's a medicine. There's a medicine called Digifab that binds free digoxin, so it will bring digoxin down. To know is when your potassium is low, you got a lot higher chance of being dig toxic, right? So you want to monitor your potassium levels too with a dig. And when your potassium is high, it can decrease the effectiveness of your DIG. So your potassium is, if you're administering a potassium on somebody, which very often is the case, because if the person is on DIG, there's a good chance they're also on furosemide, and that screws around with your potassium level. So you might be giving them potassium. So it's important that you keep that potassium level in the normal range. So potassium level and the DIG level, those are things that you're going to be looking at when somebody's on DIG. Now I'm going to talk about an atrial septal defect. Now the problem here is, with a hole up here in the atria. And instead of that coming through there, you got this hole going through the atria. Kind of hard to see because of these. Maybe I should get rid of these upper vessels so that you can see this better, because I don't think we need them. Get rid of those so that you can see. So that you can see that you got the hole there in the atrial septum. So with that hole in here, and this here is a hole that you have in utero. So it's a hole that is in the fetus because it's there because mom is oxygenating the blood. So all the blood coming through here that's coming from mom through the umbilicus and coming through the placenta, the umbilicus, and coming into the baby. You don't have to have all that, right? I was saying before, you got equal amounts going to the lungs as you got going to the system, right? You don't need all that going in there because the only blood that the lungs need is for their own nourishment. They're not oxygenating anything. So the blood coming into here does not have to go out. All of it does not have to go out to the lungs. So some of it will go out it will come down here and go out to the lungs, but a lot of it, when this beats, will get squirted over into here, right? So that way you're taking half of your blood and going off the lungs and another half. So you're increasing the amount of blood going out to the system because there's a lot going on in this baby, right? This baby is just, they got all kinds of cell division going on, all kinds of energy. They need all the blood they can get, right? Because the blood contains all these building block proteins, right? It contains all the nourishment, all the oxygen. That's what it needs. So that's what's going on out there. So you get more blood. So that's one of the things. Plus you have that ductus arteriosus, or what it is it's a little duct here coming from here. It comes under. Well, actually, it goes on. Yeah, I don't have this anatomically correct, but I'm just going to draw it there so you know that you have that guy there, right? And that's in utero. You have that, and you have this hole here. It's how it's supposed to be. Unfortunately, sometimes this guy doesn't close up, right? The atrial septal defect doesn't close up. It doesn't close up right. So when it doesn't close up right, you end up with this hole in here. So just like down here, you should have a left to right shunt because there's a higher pressure on the left side of the heart than there is in the right side of the heart. So when it beats, after the baby's been born, and this guy here is going to close up, but you're going to have your blood coming through like this every time it beats. It's supposed to be beating blood down into here, and then it can go out the aorta. But what it does is it squirts. So you end up with, and I'm going to change that there to the atrial. Because now we're talking about an ASD, an atrial septal defect. You still should have a left to right shunt, right? One thing about it, though, down here when we were talking in the ventricles, it's pretty sure thing that you're going to have a left to right shunt all the time. Because the ventricle has the highest pressure in the heart, right? But over here, you do have a higher pressure than you have over here, so you get that, but they're a lot closer. They're not as drastically different. So when things change in the system, right, or things change like bowel movement or grunting or activity or something like that, you might actually get instead of the left to right, you might get the right to left shunting, just for a minute or two, right? Yeah, usually big. They might get a little lightheaded. They might have, right? So high activity can do that because if you think about an activity, what's happening, right? You're using more blood out in the system. Your veins are doing all this moving around, and that's how blood moves through the veins. So it returns back to the heart quicker, increasing your your pressure here because you got a higher return, and when you get a higher return down in the capillary beds, you're pulling blood through the capillary bed, so you're pulling it out through the um, uh, arterial side, right? So they have to, so with this increased activity, they have to vasodilate to get more oxygen in to the things, right? And another thing is that the cells themselves are saying we need more oxygen, so they vasodilate. Activity causes heating. When your system starts heating up, it causes vasodilation, so you're kind of decreasing this vascular resistance. So a lot of times you can, during those times, you can end up with this right to left shunt. A big one too is, like I said, a bowel movement or something, because the bowel movement stimulates the parasympathetics, and the parasympathetics are stimulated. That's the digest part of rest and digest, right? So it increases your circulation into your gut, right? So it's increasing all that circulation because you're resting. It's a good time to digest. You need the blood in there to make the exchange. So by increasing that, you are decreasing the systemic resistance, and so that means that the pressure here is going to get a little bit lower, and that little bit of difference down here make a big difference. Up here, that little bit of difference is enough of a difference that you can end up with temporary right to left shunting. And like I said, not usually a real big problem, not usually anything that kills them, but it is something that can cause this problem. You can end up with strokes. And the reason that can happen is because we always get little microemboli forming. Little clots forming here and there in little corners and around little valves and stuff. We get these guys forming, and they come back up to the heart, right, through the superior and inferior vena cava. They come back up to the heart, boom, and then get blown over to the lungs, right? Because everything in my system returns to the right side of my heart and goes to my lungs before it goes anywhere else. So when you get these microemboli, they come there, and think of the lungs not only as an oxygenated thing, but as a big filter for all these microemboli. These microemboli come out there, they come up into the right heart, they go into the lungs, they get caught up in the massive capillary beds of the lungs, and they get caught in there, and they hang on to them, and the system can get rid of them, right? They don't go out and cause problems in the rest of the system. And hopefully it's a little PE, hopefully not a big PE, then it is a problem. But what happens when you have atrial septal defect, and like I said, you can end up with the shunting going from the right to left once in a while. If you happen to have one of these microemboli coming down through here, and you get the shunt, it goes over to the left. They call that a paradoxical emboli. So it goes from the left side, right? Can I spell paradoxical? Doxical emboli. E-M-B-O-L-I. Emboli. Okay, so paradoxical, that looks like crap. Let's go like this here. So you got a paradoxical emboli, which means that the emboli that's supposed to go over there went over to the other side. It's a paradox. So it goes over to the left side, boom, out to the system. It can land in the brain, cause a little. They're usually small, but they can cause a little bit of a stroke, or they can cause problems off in the other system, and get down into the kidneys. So they can do other things. So that is one thing, one problem that you might see here that you don't really see when you have the ventricular septal defects. But the atrial septal defect, that is something that can happen. But you will have, kind of like what I was talking about down here, you have that same problem that you had down here, is that you are transferring the higher pressure of the left side of the heart over to the right side of the heart. Not as drastically as the ventricular septal defect does, but it still does. And over time, that increased pressure has to strengthen the right ventricular myocardium, and so now it starts pushing out with more force. And when it starts pushing out with more force, it pushes out into the lungs, and you get that. So over a couple of decades, right? It doesn't happen real quick, but over a couple of decades, this person has a much greater chance of developing problems in their 20s and 30s that a person in their 20s and 30s shouldn't be developing, mainly congestive heart failure with pulmonary edema, stroke, things like that. So this needs to be repaired. And they can repair it just by cannulating through here. They got the newest system now where they don't have to, and I don't know all the details, but they don't have to. There's some great YouTubes out there on them, but they can cannulate through here, and they come in through the superior or inferior vena cava, depending on if they come through here or come down here. I think they usually use up here, so they'll come in through the superior vena cava in here, and then they take this little Dacron patch thing, I think it is, and it comes in here, and it ends up going, they push it through there and they patch it, and it's made of this matrix of stuff that scar tissue can grow on real easy. So, and it's kind of a neat procedure, and I could maybe get you a YouTube address so that you can see it, see how they do it, because I saw one on YouTube and they explained it perfectly. I can't really do that right here, right now, not like they did. You know, they have moving video and everything. So that's the ventricular septal defect. And let's see here, what I got to tell you here. It's getting kind of dark in here, but when I turn on the light, the big light here, it puts a big glare on the board and you can't see it. So I got to kind of squint my eyes here. With your atrial septal defect, one way that you can detect it early on is when you're listening to the heart tones. What you'll hear, you might hear a little bit of a murmur in there, but mainly what you'll hear, the thing that gives it away, is you're going to be hearing a splitting S2. Now I talked lub-dub when I was talking about the ventricular septal defect, but I didn't say S1 and S2. Lub is S1, dub is S2. That's more, okay, we'll just go with that. So S1, S2, right? And remember, I had those drawn in here. I took them out so you could see the hole in the thing here. But you have these guys here coming out up to the aorta and out to the pulmonary artery. So you've got the pulmonic valve and the aortic valve, right? When they slam shut, it's dub. That's S2. When the mitral valve and the tricuspid valve slam shut, that's lub, right? And that's S1. So S1, S2, S1, S2, boom, 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 boom. What happens with this hole is, where this hole is, and you got that pressure coming through there, you'll have that right when that beats, and then this beats. What it does is it delays this, so it doesn't slam shut right at the exact same time as the aortic valve does. And I'm going to go ahead and I'm just going to draw these valves in. I hate just pointing at a hole in the wall there, right? These valves here are heading up to there, right? This here is heading up to there, right? So up to the aorta. So you got that valve. You got this valve, right? So you got beep, 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 right? Lub, dub, lub, dub, lub, dub, lub, dub. I guess I'll say lub, dub, right? S1, S2, S1, S2, lub, dub, lub, dub, lub, da, dub, lub, da, dub, lub, da, dub. Instead of lub, dub, it's lub, da, dub, lub, da, dub, lub, da, dub. Because this one's just delayed. It's just a little bit behind. So by being just a little bit behind, you're getting that lub, da, dub, lub, da, dub, lub, da, dub, instead of lub, dub, lub, dub, lub, dub. They call it a splitting S2. Because lub is S1, dub is S2. S1, S2, S1, S2, S1, S2, right? Lub, dub, lub, dub, lub, da, dub, lub, da, dub, lub, da, dub, lub, da, dub, right? So they're not slamming shut at the exact same time because of this ASD deformity. So that splitting S2, know that. It's an important thing to know. Signs and symptoms, they're going to vary greatly depending on the size of the hole. You got a really big hole there, they can have some pretty bad symptoms, right? So they can problems with hypoxia, right? They'll have problems with hypoxia. And when do they have problems? They're going to have problems with activity, right? They're going to have the problems mainly with activity when their system needs more oxygen. That's when they have their problem. So increased pulmonary problems because of the increased pulmonary, right? Sounds pretty much like the ventricular septal defect I just talked about. A lot of the same stuff here happens here, except the splitting S2 instead of that murmur I was talking about before. Problems can be atrial fibrillation and atrial flutter because you get this distortion here, and you might get hypertrophy, in other words, enlargement of the atrium up here, right? Because it's getting this extra blood that it's got to deal with, so it's getting bigger and stronger. It's getting hypertrophied, and it can distort your conduction pathways, your atrial conduction pathways that come through here. So you can end up with atrial fibrillation, where the top just ends up quivering because it's not following its normal pathways, or atrial flutter, where it's just going really fast, right? So those are common problems that you can end up with. Okay, we got one more defect to talk about. It's Tetralogy of Falot. And this is the funnest one of the whole bunch, right? Because it's kind of an interesting defect. I guess I got to draw the damn heart up here again. I'll erase the thing. It was getting kind of messy, though. Okay, we got one more thing to talk about here, and it's Tetralogy of Falot. It is a congenital heart defect. Tetralogy, which means four in whatever, Greek or Rome, Latin or whatever. Tetralogy of Falot, F, maybe, I think it might be French, because I think Falot is a French name. F-A-L-L-O-T. Yeah, that's got to be a French name. So tetralogy, I think it must be French. Who cares? Tetralogy of Falot. Four things go wrong. That's what you got to do. The tetra means four things. Tetra. Remember that game Tetra? You guys might not know what that is. It's a game where there were like four blocks, and you got to try to make them as they fall, whatever. So tetralogy of Falot. Four things go wrong. Aortic valve, right here. One, aortic valve stenosis. What's stenosis mean? Thickening, hardening, right? So it's not working well, right? It's thinned, right? So you're not gonna be able to push through there. So you're gonna have resistance there. So that's that's one thing that's going wrong. Another problem that you have here is that you're gonna see in here. Let's just go here. Ventricular, right ventricular hypertrophy. Right hypertrophy. Right, you see that hypertrophy? No, you can't see it. There, right ventricular hypertrophy. That's what that says. Number three. Let's see, right, ventricular hypertrophy. Ventricular septal defect, VSD, right? That's the third thing there going wrong. Let's see. So you got that, you got this, and then four is the overriding, I guess, got to be two words, overriding aorta. aorta or aortic valve, whatever. This guy here. And now I will explain what all that means. And it all follows. And I'm going to just kind of go through the progression of this problem in the fetus, or whenever it's as the baby's developing in the mom. So you got all these problems here. And put this in here too. The little trap door, right? You got your tricuspid valve, you got your mitral valve. So you've got your aortic valve here. And I'm sorry, your pulmonary valve, your pulmonic valve, and you've got your aortic valve over here. So now, let's say this baby here is born for some damn reason. He's got this problem here. He's got this stenosis right here. I need my blue marker here to show this. This guy here got a thickening of the wall here. I'm going to draw it as that there. I'm going to draw it like that. Right? So now, this guy here has to work really hard to pump through there. So you're going to end up with right ventricular hypertrophy, because this guy gets really big and really blown up as it's working so hard. It's like it's working out, right? You're out there hitting the weights, right? You just pump, 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 pump. And this guy here is working really hard, so you get this hypertrophy. This is big enough you can actually see it on X-ray. You can see it. They call it a boot shape, because this kind of comes down, and you got the other stuff up there. I guess it makes it look like a boot. I don't know, but so you got this hypertrophy here, right? Usually this is way bigger than this one. See how I drew it there? Now that's way bigger. So now it's pushing out with a lot of force to get through there. And remember how before, when I was talking about the ventricular septal defect, I talked about how this comes up from this side, right? As this is growing, this grows up this way and this grows down that way, and they kind of meet in the middle, right? And then the top here has got to kind of meet up with it there, and they fuse together like that. We've got this pushing on it. Got all that pushing. So it bends over some of these guys. You end up with a hole in there. So you end up with a ventricular septal defect. It's pushing on that. Right? It doesn't allow it to fuse together right? So you got that fusing again, right? Have I got that drawn in there? Yeah. Right, got that hole, So you end up with this. You end up with the hole in here. So now you got this defect. Another thing is you're pushing and you're pushing all this. So you're throwing off the form of the myocardium, right? The proper form and developmental form of this. So it's kind of pushed this guy over here instead of it coming up nice and straight like that. It's kind of off like this, right? And this guy here, the overriding aorta, has been kind of sprinkled back over like this. Right? So now, normally when you've got this here, all this here kind of caused all this chain reaction of things. I don't know if that's the right progression, but it's the way it works really good in my brain. And I've seen different ways where different cardiologists have explained the progression. It doesn't matter. What matters is that you understand the problem here and how it works. So as this guy is pushing, you're getting all this force from this strong right myocardium pushing, and it ends up pushing there. So you end up with, instead of having your left to right shunt up shunting like you normally do in a ventricular septal defect, you end up with right to left shunting, right? So that's the problem, right? So you end up with this right to left shunt, right? Because you got all this force over here. This guy that it's worked out so hard trying to push through there, through this pulmonic valve stenosis. And then you got this here, this overriding aorta. So when it pushes over like this, it's pushing off into this side. So you got your blue blood over here. Some of it comes up through here. Some of it comes over in here, right? And you've got your red blood coming from the system, or you got your red blood coming from the lungs, right? Comes over to the lungs because it's still, you can get oxygenated in the blood, in the lungs, comes over in the lungs, and it mixes with it. So then you end up with what we like to call purple blood, right? So you end up with this purple blood. Does that look purple on the thing there? I hope so. So you end up with this purple blood as it mixes and it's going out here. Right? So you end up with purple blood. In other words, it's not oxygenated as well as what you would like it to be oxygenated. Another problem that happens here. Let's get rid of all this crap here, just so you can see what I'm about to draw here. You've got your blood. You've got this guy here, and it's going to be below. It's going to be pushing up there. You've got this overriding aorta. And depending, now remember, this is a three-dimensional thing, so that hole is going in there. That hole happens to line up with this aortic valve, and this guy is overriding, and this is pushing everything that way, right? Because you got all this power down in here pushing off to that side, pushing against this septum, and it pushes right off here. So it just straight into the aorta. Right, you got that straight shot. Boom, it's pushing it off into the aorta. This guy's stenosed. The aorta's fine, so it takes it easy. A lot more pressure here than there is here. So you're getting more blood, more of this blood going off into that side than you are over into this side. So it's the severity of this thing really depends on how stenosed this is. Right? How bad is this stenosis? If it's really bad, you're going to get a lot of shunting. And you need to get more blood going over to the lungs, right? And we'll talk about it. So for this guy here, you're going to have a really obvious heart murmur. So if they detect this when they're babies, they can give them this prostaglandin E, and it is called, I had to look this up, aprostadil. Aprostadil is the name of this medicine. Aprostadil. So we look at this, make sure that I spell it right. Aprostadil. Aprostadil, yes. And what that is it's prostaglandin E. And I guess what prostaglandin E does, by looking at this, I mean, this is, it's used for other things too, but prostaglandin E does is it keeps this open. Remember when I talked about the hole there in the ventricular septal wall, the hole in the atrial septal wall? It keeps that hole open. This prostaglandin E does, and when you're born, it's supposed to, the amount of that prostaglandin E drops. That's one of the reasons that hole is supposed to close back up. What the prostaglandin E does is it keeps the ductus arteriosus open. And I don't want to do that with this color. Let me give you this here. Right, you got this arteriosus, and this is not anatomically correct at all. I mean, really, the way it's supposed to draw this is this guy here goes underneath there and out like that. So then the ductus arteriosus is just a little vessel going through like that. But I can't draw that well. So I'm just drawing that in to show you that in utero you have this connection between those two. And like I was saying before, in utero, it's for the reason of mixing. You want more of the blood going off to the system. But now, the reason that we give them this prostaglandin E is to keep that guy open, to stop that from closing. And the reason we don't want that to close is because we want the high pressure here, because this is taking it real well, right? You're not getting much in here, so you got low pressure here. Right, because not much is getting through this stenosed area, but you're pushing a lot of blood up through the aorta. So by keeping that open, as it goes up into the aorta, some of it's going to shoot back down through that ductus arteriosus and get over to the lungs. That's what you got to try to do. You're trying to get more blood going over to the lungs, and then it can return back through here, and so that can keep them alive. This can keep them alive, giving them this medicine. If they don't, If they don't catch this on time, and this guy here is already closed up, they can actually go in there and do a surgery, a temporary surgery, where they put those two, and I don't remember what they call it, a Blakemore or something, but that doesn't matter. But they can do a temporary surgery to put a stent across there if they can't keep that open. So they can temporarily put a stent in there, or they can give them the prosthetic knee, and they can come in here and try to open that up with an angioplasty and maybe put a stent in there just to open that up so that they can decrease the amount of, so that they can increase the amount of blood going up through the pulmonary artery. If they can open that up a little bit, you can cut down on all of these problems. They cut down on all of these problems. Baby can be stable enough to wait till they're about 6 months old. Maybe, I think like between 5 months and a year is where they like to, that's their goal, is to do the surgery at about that time. They used to wait till they were like two or three, but now they can do that. They can do the surgery because they might get by without opening them all the way up and going in and doing things like fixing this, patching that, like we saw with the VSD. And if they can get this fixed and then get that patched, this kid's going to do all right. You know, they'll do okay. But in the meantime, when you got a baby, years ago, they didn't know what this was, but they knew that these kids with these certain symptoms, where they would get hypoxic and everything, a little bit of activity, and they're really hypoxic. And they knew that these kids that had this problem would they would turn blue and they couldn't breathe, and they were toddlers and run around and they'd stop and they would squat. They would just squat down and just sit there for a few minutes because they learned on their own that made them feel better. And so we kind of have that in with our nursing care. And what we do, I mean, we're talking babies now because hopefully we can repair them before they're toddlers. But we've incorporated that knowledge that we got from these toddlers into our nursing care. And I will explain to you how that works, what happens there. But when baby gets active, we've got kind of when I was talking about ASD, a baby gets active, you get vasodilation out in the system, right? The system is taking more blood, it's using more blood because of this activity. So you've decreased your amount of systemic vascular resistance, right? So because it needs more oxygen going out there. So when you decrease this, you're decreasing the pressure over here, and you're increasing the amount of shunting that will go on, right? So the aorta is taking more now. So it's taking more, and so that means less is going through here. So you're getting more of the blue blood over into that side, even more than what we're getting before, right? So maybe instead of being purple, it's really purple to the blue side. Instead, we want purple to the right side. You're not going to get red, but you can get purple to the right side. And I hope you understand what I'm talking about. Red would be oxygenated blood, blue would be unoxygenated blood, purple is half and half. So if it's purple to the blue side, that means that it's more unoxygenated than oxygenated. If it's purple to the red side, that means it's more oxygenated than unoxygenated. This is something I just made up just now. But so now we're coming. You got this blood coming through like this. The baby has done it. The baby had, this toddler back in the day was running around and doing this stuff, and he'd squat and he'd feel better. But they call these TET spells, or blue baby spells, and what they are is they are spells with activity. They get very cyanotic and very short of breath. This is a life-threatening problem. They have to be dealt with immediately. And what do? Well, nowadays, like I said, the baby squatted. How come he squatted? By squatting, he's putting a kink down in these major blood vessels. He's kinking them up. So he's increased. Instead of having all that blood going down there, he's increasing the resistance out there in the system. It's like you got a hose going down through there, and you took somewhere in that hose, you grabbed it and you twisted, and you twisted it closed like that, right? Well, the blood isn't going to get through there. You've increased the resistance. So by increasing the resistance, the blood isn't going to go up through there so much, right? Because this is like a hose going down through there. If somebody took it and clamped it off, boom, won't go through there. Will go to the lungs. So now you're going to start oxygenating more blood. Not only that, the kid ain't running around anymore either. Well, when you got a baby, when do they have problems? When they cry real hard, right? They cry real hard, they feel bad, right? They usually learn not to cry real hard. Amazing what an infant can learn. But eating is the big one. They have to eat. They want to eat. Everything tells them to eat. If they don't eat, they'll die, right? Just like anybody else. If you don't eat, you'll die. You got to eat. So the baby, by instinct, is going to eat, going to work really hard to eat, and they can overwork themselves when they're eating. So feeding is the big problem. So when they're feeding, they can start to get this problem where they start turning blue. You can lay them on their back, bend their legs up, right? You just bend those legs up, you're kinking that hose, you're increasing that resistance, and more of the blood is going to go to the lungs than out to the body. So that's one of the cares. Another care, what else would you do? You could give them IV fluids. By giving them IV fluids, you're filling up the system there, you're increasing the pressure, increasing the resistance out here, so then hopefully more of the blood will go out to the system. Yeah, and like I said, the activity will usually decrease the resistance, the systemic vascular resistance, and the reason it does that is because your system needs more blood, so your cells start asking for more blood, so you end up with vasodilation, which decreases the resistance. And activity, like I was saying before, activity increases the temperature, so your system has to get rid of the temperature, so it vasodilates. Right? You get flushed and stuff when you're really active, right? You're out there running, you get flushed face and everything. That's because you're vasodilating all the blood vessels out on the surface of the skin to let off this heat. So that's why they end up doing that. But by putting that kink in the system, you can counteract that. Hopefully, that's the goal. And then, from what I'm told, it usually works. I've never been fortunate enough or unfortunate enough to have to do that. And I think I've gone through these three systems. So I think we're done. All I gotta do is edit this stupid thing here.